Hello, everybody. I am Dr. Sanjay Sood. I am a diabetologist practicing in the southern part of West Bengal in the country of India. The town where I practice is called Shirampur, and I have a diabetic clinic. And I have been practicing diabetology for the last 22 years. So today I will be presenting or rather discussing a case study of a newly diagnosed type 2 diabetic patient who had a high baseline HbA1c. So, this patient, Mr. AB, who's 45 years old, was newly diagnosed with type 2 diabetes mellitus and visited my clinic 6 months back with multiple risk factors like obesity, hypertension, and hyperlipidemia. He was initiated with metformin with advice for lifestyle and diet modification. Recently, he visited again as part of routine checkup, and his laboratory work showed the following reports. HbA1c was 8.5%, that is way higher than the goal we consider 7% or less. EGFR was 80 ml per minute. LDL was 80 milligrams per deciliter. HDL 38 milligrams per deciliter. Triglycerides 200 milligrams per deciliter. The medications that he was taking were the following: metformin 1000 milligram twice a day, lisinopril 40 milligram once daily, metoprolol extended release 100 milligram once daily, atorvastatin 40 milligram once daily, and aspirin 75 milligram once daily. And on physical examination, the patient was found to be obese. His BMI was 31 kilograms per meter square. Blood pressure was normal, 120 over 70 millimeters of mercury, and the heart rate was 78 beats per minute. Now, evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complications in type 2 diabetes, as per the UKPDS study. UKPDS demonstrated a legacy effect of early intensive therapy because the difference in the CV event rate 10 years post-trial was apparent even though no difference in HbA1c levels between the intensive and conventional therapy. When metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve target more quickly, particularly in patients with high baseline HbA1c level. Early combination therapy in type 2 diabetes makes clinical sense for several reasons. First, a meta-analysis demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of less than 7% of HbA1c compared with metformin monotherapy. For patients with HbA1c more than 1.5% above the goal at diagnosis, the ADA and EASD guidelines recommend first-line treatment with a dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients with established cardiovascular disease, congestive heart failure, or chronic kidney disease. IMPA and LINA combination with complementary mechanisms and pleiotropic benefits may be suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or high risk, established heart failure or chronic kidney disease due to the tolerability of the combination in addition to the potential benefits of empagliflozin on the cardiovascular and renal outcomes, and no increased risk of heart failure with either agent. According to study, early achievement of HbA1c goal less than 7% with Impalina could reach target HbA1c at 12 weeks compared to monotherapies. HbA1c decrements by Impalina 25 mg plus 5 mg has demonstrated 1.81% HbA1c reduction at HbA1c baseline of 8.5% or more at 24 weeks in metformin treated groups. The benefits on glycemic control were maintained at week 52, that is beyond a year too, in metformin treated groups, and a higher percentage of patients achieving HbA1c of less than 7% were reported for combinations. The combination offers a suitable component in strategy to achieve target HbA1c without increased risk of hyperglycemia and weight gain, with improvement in overall lipid profile, a reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when a DPP4 inhibitor is added. The reason perhaps because of a better glucose control, although other possible mechanisms remain to be investigated. So in summary, Empalina fixed dose combinations provides a robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the goal HbA1c compared to individual agents with low hypoglycemic risk. So it is always prudent to begin in such a case setting as I was describing in with a combination of SGLT2 inhibitor and a DPP4 inhibitor, and what else will be best, empagliflozin and linagliptin in a fixed dose tablet. Thank you very much.